Good afternoon, everyone. I'm Mr. Cledera. I'm here to present an interesting case presentation. It's on patient RMA, a 41-year-old male. I presented at the ER 4 hours prior to consult, presented with left hemianopsia, neglect, loss of balance, left facial asymmetry, and dizziness. He declared that he had no known comorbidities, and allegedly the family history was unremarkable for this patient. So at the ER, a BAT was activated. On cranial MRIs, an eggshell DWI image, as pointed by the yellow arrows, is the areas of DWI hyperintensity at the insula, right parietal occipital lobe and left temporal occipital lobe cortices. On ADC, the same foci of hyperintensity demonstrates signal count, demonstrating restricted diffusion. On T2 and FLAIR, only the focus at the left temporal occipital lobe showed T2 and FLAIR hyperintensity. A similar signal foci was seen at the level of the center of Celio Valley. Again, showing signal drop in AEC. These lesions did not show any T2 or FLAIR hyperintensity. So 3D recon of the MRA of the patient was unremarkable. So the findings in this patient were hyperacute infarcts of the right corona radiata, the right insula and right parietal temporal lobes. There's a small acute infarct of the left cortical temporal occipital lobe. And the MRA for this patient was unremarkable. Given the distribution of the infarcts, cardioembolic etiology was ruled out. A point of care to the echocardiogram was done at the ER. So these are the four-chamber and short axis views for these patients. Annotations in green have been provided so that we can orient ourselves with the images. So as pointed by the yellow arrow, it's noted that this patient had eccentric left ventricular hypertrophy. You can also see that there are prominent trabeculations on the wall of the left ventricle. You can also see them in the short axis view as pointed on the violet arrows. Functionally, the ejection fraction in this patient is around 22%. Other findings seen in this patient, you can see significant regurgitation at the mitral and tricuspid valves. So the findings of 2D echo for this patient, there's eccentric left ventricular hypertrophy, increased ventricular mass, there's prominent trabeculations, and normal relative wall thickness. The right ventricle is also dilated with hypokinesia, and we saw severe mitral and tricuspid regurgitation. For further evaluation, since the findings were specific, a cardiac MRI was ordered. So these are cine images. The cine images, a four-chamber view and ventricular long axis. Again, annotations have been provided. Remove them for now. As pointed by the yellow arrow, we can see prominent trabeculations in the inner wall of the myocardium. On the four chambers pointed by the yellow arrow, there we can see them on the lateral wall of the left ventricle. On the ventricular long axis views pointed by the violet arrow, you can see them also at the inferior wall. Incidentally, we also see the findings of tricuspid mitral regurgitation in this patient as evidenced by regurgitant flow jets. So this is a two-chamber view, again with annotations. Pointed by the yellow arrow, we can again see these prominent trabeculations on the inferior wall. The image on your right is a more lateral view of the same two-chamber image. You can much better appreciate these trabeculations. They appear net-like or even mesh-like. So this is a short axis view of the heart. For the fellow residents to read CT or MR, think of this as the action view of the heart. So this is taken at the level of the mid-ventricle. To better appreciate the pathology that we are seeing in this image, let's compare it to a normal short axis. So when you compare the two images, you can see that there's global hypokinesia of the left ventricle. The right ventricle also appears hypokinetic, and the left ventricle and the cavity also appears dilated. Again, we see the prominent trabeculations. You can see them on the anterior, lateral, and inferior walls. These trabeculations have spaces or recesses, where you can see there's blood flowing in between. And you can also see the same trabeculations in the right ventricle. Now, functional volumes done in this patient showed biventricular systolic dysfunction, most severely in the left ventricle. And if you focus on the area encircled on green, you can see areas of hypointensity or signal saturation within the ventricular cavity. These reflect intracavitary flow stasis. So these are short axis views taken at the base and apex of the ventricle. We can also appreciate the prominent trabeculations as pointed by the arrow here and also here. So if you take a measurement, the prominent trabeculations appear non-compacted. So we take a measurement of that, while the compacted myocardial wall we also measure. We take the measurement of the non-compacted divided by the compacted, and it appears to be greater than 2. These were also measured at the base and apex of the ventricle as well. Additional findings on this patient is pointed by the yellow arrows. At the apex, we can see these hypointense nodular filling defects that don't appear to be part of the prominent trabeculations. You can also see it here in the 4-chamber view as pointed by the violet arrow. T1 mapping for this patient at the level of the apex, mid, and basal ventricle, it was around 1090 milliseconds. So it reflects a mild increase in T1 signals. Usually the normal in our institution is around 900 to 1050. TQ mapping done in this patient, we look for edema. On the 6 segments of the ventricle, the relaxation times range from 48 to 55 milliseconds, which are also normal. These are single shot steer images of the 4-chamber view and short axis view. There was no hyperintense signal seen in the myocardial walls. However, if you look at the hyperintense signal seen within the cavity as pointed by the arrows, we are in the same region as the prominent trabeculations. These also support our findings of intracavitary flow stasis. If you remember the nodular filling defects that we saw at the apex earlier, here they're better defined in these early gadolinium enhancement images as pointed by the arrows. We measured them around 7 and 6 millimeters, so this possibly reflect organizing clots. Late gadolinium enhancement in this patient showed no focus of late gadolinium enhancement. Bright field TP images of the mediastinum, the chest, and vascular structures were mostly unremarkable. We just saw pleural effusion in this patient and a small circumferential pericardial effusion. So the findings we saw in this patient, cardiac MRI, saw dilated left ventricle with wall motion abnormality and severely reduced systolic function with hypertrabeculated subendocardium of the left ventricular walls. Now, these findings are consistent with left ventricular non-compaction. Also in this patient, we saw global mild increase in T1 signals. However, there was no corresponding late gadolinium enhancement, so this may possibly reflect increased interstitial space. We also had dilated right ventricle and left and right atrium, and findings of organizing clots at the apex. Unfortunately for this patient, 2 days after the MRI, he had another brain attack, and it showed new infarcts to the left frontal lobe and also at the operculum. Eventually, this patient recovered and was discharged. So, what is left ventricular non-compaction? So, in the literature, it's a relatively new cardiomyopathy characterized by prominent trabeculations and deep recesses. It doesn't estimate prevalence. However, the true prevalence is still unclear. This can be genetically heterogeneous, can occur in sporadic and familial forms. It tends to favor males more than females, and it can be an isolated or non-isolated type, which means that it can be seen with congenital heart disease. So in the current literature, there is controversy whether left ventricular non-compaction is a congenital abnormality as the result of arrest of normal compaction process in utero, or if it is acquired during life. So in this diagram here provided, so during early embryological development, so the myocardium is a loose meshwork of trabeculations and recesses that communicate with the left ventricular cavity. So usually by the fifth and eighth week, the myocardium becomes compacted. So it proceeds from basal to apex and septum to lateral wall. So the current theory is that the process of myocardial compaction is disrupted. However, the mechanisms through which are still unknown. The severity of non-compaction is dependent on the stage at which the arrest of the normal embryonic myocardial maturation takes place. So clinical findings in these patients, they can vary from no symptoms or to heart failure or fetal arrhythmia. So this entity can actually be insidious. More advanced patients can present with heart failure in 50%. Usually the heart failure is secondary to the synchrony between the non-compacted and compacted myocardium. These patients are at risk for embolic events because of development of thrombi in the trabeculated myocardium. Think of it as increasing the surface area of the heart, and with a mesh-like structure, net-like structure, so it favors the formation of clots. You see, these patients can also present with arrhythmogenic substrates from the subendocardial fibrosis, but that's only seen in more advanced cases. And usually, life-threatening ventricular tachycardias have been reported in 20% or more of patients, and usually it's a concern for sudden cardiac death in patients with advanced disease. Imaging findings for this patient, usually echocardiography, which is the most frequently used imaging modality. It's the first choice technique for patients because, of course, low cost and it's widespread. Usually, similar to cardiac MRI, we take it at an end-systolic ratio within the non-compacted and compacted layers. So the measurement is more than to its diagnostic. Limitations in these modalities, like ultrasound, it's operator dependent, and usually a pitfall here is that normal trabeculations can be mistaken for abnormal. Multi-detector CT can also be used, can delineate prominent trabeculations. However, compared to echo and MRI, it's less used due to ionizing radiation and lower capability for tissue characterization. However, compared to the two, it has a potential advantage to evaluate the coronaries. As we saw in the index case, so cardiac MRI should be performed to confirm diagnosis we've seen on echo. So usually since MRI has superior image quality, it has increased sensitivity in the detection of trabeculations. Usually classically, the diagnosis done at end diastole compared to end systole from echo, and the ratio more than 2 is on the diagnostic. However, consensus is still being debated. So sometimes you see ranges of 2.3 or 2.5. 3 in some cases. Also, MRI helps image the entire heart as well as the mediastinal structures to rule out other structural pathologies. And compared to echo, the right ventricle is better visualized on MRI uh, because of the variant anatomy in patients who are scanning during echo. So sometimes the right ventricle can't be seen in that modality. And another benefit is it allows tissue characterization, which helps differentiate it from other entities. So what are the differentials for this pathology? You know, so two main differentials could be an atypical hypertrophic cardiomyopathy, seen here, or a dilated cardiomyopathy. Sometimes the atypical hypertrophic cardiomyopathy variant can still subtype can be mistaken, especially at the region of the apex. However, if identification of prominent trabeculations is key to diagnosis, usually in dilated cardiomyopathy, it can be difficult to differentiate the two, although the presence of tuberculation is more suggestive. It's important to remember 50% of patients with non-compaction also have a dilated left ventricle and depressed systole and depressed ejection fraction, which is also seen in our patient. So we also noted that there are trabeculations in the right ventricle of this patient. So this is another image of our index case. This is a dedicated RA view or right atrium right ventricle view. So currently there's no established criteria for right ventricular non-compaction. It's actually still controversial towards the diagnosis. It's been reported in newborns with congenital heart disease. And there's also correlation right now with adult patients presenting with neurological symptoms. However, the reports are still very few. Usually an isolated form is extremely rare, especially so it's more commonly seen with congenital heart disease. Management for this case, no specific therapy has yet been validated, but prevention of embolic events in these patients is an important management goal. ICD implantation in these patients is still controversial. However, the benefit of it preventing life-threatening ventricular tachycardia is still much better. So these are my references. Thank you.
Thank you so much. Thank you so much, Dr. Cledera. Exceptional. Thank you. Thank you so much. Going back to your patient, I would just like to ask again. So the patient's initial presentation was the stroke, ischemic stroke, correct?
Yes, though.
And according to the presentation on the stroke, there have been small foci of restricted diffusion. So the consideration at that time was cardioembolic event. So
Yes, though.
after that consideration, it was only then afterwards that the cardiac imaging diagnostics were performed from echo to MRI. And thank you very much, Dr. Turl, for walking us through step by step on how to identify this interesting case. Indeed, it is very interesting. So started with neurologic problem and then cardiogenic cause. Had it been the other way around, did the patient present with cardiac problems before the present neurologic presentation? Did he show signs of cardiac problems?
That was actually the interesting part in this case because this patient, he said he had prior to experiencing the neurological symptoms, he denied that he ever experienced any heart failure symptoms or cardiac symptoms at all.
Mm-hmm. I see. Because the neurologic problem came about due to the development of thrombi from the irregularly thick and trabeculated myocardium.
Yes.
So the patient did not present any clinical cardiac problems. So were you able to convene with a cardiologist? What would have been done to somehow prevent such problems?
For this patient's case, though, it was really clinically silent.
Mm,
The problem with this patient is that he really did not, he allegedly did not have any cardiac symptoms at all. So he didn't really feel the need to have a checkup done before this. And
I
usually,
see.
typically in non-ischemic cardiomyopathy, such as hypertrophic cardiomyopathy and also non-compaction, sometimes the disease course is clinically silent. So there's sometimes our referrals will usually get them when they present with sudden syncope or when we have uh, ventricular tachycardia in an apparently healthy patient.
All right. Thank you. Thank you for pointing that out. A silent killer in this case. I would like to open the floor for comments and questions for our presenter, Dr. Thurl Cledera. Thank you again.
I have a question.
Doctor,
Did they give antiplatelets or anticoagulants?
They did though.
So which one?
Uh, According to what I got though, they gave anticoagulants at the ER
So-
setting.
So you have to okay, ER setting. Pero for maintenance, antiplatelets should be enough, or do we have to set an INR?
I think though, you'll have to consider the INR. Although though, I'm not familiar if antiplatelets would be given to these patients as well as maintenance.
Kasi, di ba, sabi mo prevent thrombosis na lang, di ba? Yun yung main goal nila.
Yes, though.
Sige, I'll make some research. This is interesting because, a lot of times we have strokes in younger people and we always attribute it to drugs, di ba?
Yes, though.
To cocaine and shabu. But pwede pala ito, or pwede, di ba, or the AF, or mga septal defects. Pero this is really interesting. Thank you.
Thank you, Doc.
Hi, Doc. Good afternoon. Doc,
Doc.
this is Tina Corpus from Quezon City. If it's okay po, I have a clarification for Dr. Thurl.
Yes.
Okay.
Doctor, good afternoon. Thank you for that very nice and interesting presentation. I'd like to clarify lang, Doc, did the patient have a second episode of infarct? I think you said there was a second episode.
Yes, he did. 2 days after the cardiac MRI.
How many days after?
That was 2 days after the
just
cardiac
kidding.
MRI examination.
Okay, because I was wondering in relation to what Dr. Ems and Dr. Candy has said about the possible intervention, if they could have prevented that second episode sana. Thank you.
Thank you.
Thank you, Dr. Atin. That's a good point. All right. If there are no more questions, no more clarifications, Dr. Thurl, I would like to say thank you again to Dr. Joed and Dr. Thurl. Thank you for your presentation. This